So what do you know about traumatic brain injury? And over the last maybe 20, 30 years, we have been treating traumatic brain injury basically in the same way. In the recent past, with special guidelines coming up, the management strategy has been simplified, and there is evidence-based practice throughout. So let us see. We'll take off. This 35-year-old previously healthy boy came to us on the 2nd of April, met with an accident at 4:30 in the morning. Without an helmet, collided with a lorry, and admitted to Mavanella Hospital with a GCS of 10. One side, the pupil was slightly dilated. He moved all 4 limbs on admission to the hospital with a blood pressure of 100 systolic and tachycardic, breathing at about 25 with a saturation of 92 with oxygen on board. This is a common scenario that we see all the time in our ICU, all the time. So are we treating these patients right? Do we have a common method to treat these patients? So let us see what we did and what we are supposed to do. So what happened at Mavanella? At Mavanella, the primary survey and resuscitation was done. Patient was transferred here with a cervical collar and oxygen on board and with fluid resuscitation. Do we know what the reason for transfer was? Why did they transfer to Kandy? They bypassed Peradeniya and came to Kandy. Why? Because these are grade 1 hospital. So they actually had to bypass this place and came to a grade 1 hospital. Actually, because it's a neurosurgical center that they have come here. And in this particular patient, why they came here was the GCS was low. So the patient can't maintain the airway, can't protect the airway, and we are suspecting head injury, and the patient had to be transferred. And the other thing is the breathing was getting affected, oxygenation was getting affected, and if by any chance we are suspecting head injury, for therapeutic reasons, patient needs to get into a neurosurgical unit. In relation to transferring patients, do we transfer every patient that we get from a local hospital? Do we transfer? You take, for an example, a bus goes down a cliff. There are 50 people on board, and everyone comes to this Mavanella hospital. Who comes to Kandy or Peradeniya? Who comes? Who is sent? With basically head injury. So there are reasons to transfer to a unit. So these are the basic reasons why you transfer to your neurosurgical unit. Maybe the GCS is coming down. If the GCS is dropping more than 2 segments or GCS is less than 13, patient is having focal neurological signs, patient is weak on one side, patient is fitting, he has features of increased ICP like hypertension, bradycardia, there's CSF leaking, basal skull fracture. All these things are actually reasons for a patient to be transferred to a center. So in this country, of course, there are other reasons. You can be politically powerful to be transferred to a center. Other than that, all 50 patients can't be taken in. So you will have to prioritize who should come in. So this patient came into National Hospital Kandy, and we did the primary survey, stabilized the patient. We identified whether they have a life-threatening injuries, and secondary survey and definitive treatment was in process. Patient comes to the ETU Kandy. There are lots of bottles of IV fluids. Now this patient requires resuscitation. We all know that. Why the blood pressure is low, the patient is tachycardic, patient has an IV line, needs resuscitation. What kind of fluid are we going to give? What kind of fluid are we going to give? So we have a 5% dextrose, we have normal saline, we have Hartmann's, we have stereofundin, and we have Hyperosmolar. Do you want any idea? You can choose either. The nurse is bringing you a bottle. Yeah, so we all believe Hartmann's is a better, more physiological IV fluid. Then have you all heard about stereofunding? Madam uses stereofunding, so you all should know. Stereofunding is something like Hartmann's, but the difference, we don't use Hartmann's in the head injury. Reason being the osmolality is 279, where normal saline is 300. So slightly, though, for us, for a medical student, is isotonic. For us, it is slightly hypotonic. So therefore, we don't use it because cerebral edema gets worsened. And there is a bit of lactate in it, and lactate can be detrimental here in hypoxic situations. So when the nurse asks you to bring, you ask the nurse. If she asks you, what do you say? If you don't know, you say, so that is how you get about working in the ETU for the first time. Is that right, Nandana? So on primary survey and stabilization in the ETU, gurgling sounds heard, and the respiratory rate was 28, saturation is low, hypotensive, tachycardic with tube GCS dropping. So we had to intubate this patient. Why did we intubate? The GCS was low. Can't maintain airway, can't protect the airway, so we intubated. We are suspecting some head injury because the pupils are dilated on one side. So for neuroprotection, also we need to intubate and ventilate. Oxygenation is affected and respiration is marginal. So all those things are reasons to intubate and ventilate. Okay, so this patient now has been transferred for a CT scan. So going back, these are the reasons actually to transfer to a neurosurgical center. And these are the reasons why we did a contrast CT, non-contrast CT. GCS was low or it was dropping, basal skull fracture. So there's a big major list of things that needs to be figured out before you send for a CT scan. So this was actually the CT of this patient who came following a road traffic accident, hit his head on a lorry without a helmet. And what it is? What do we see here? We see a homogeneous, convex blood clot pushing the ventricle and collapsing the other side. What happens is when this becomes larger and larger, the foramen Monro gets blocked on that side and the lateral ventricles gets compressed, and on the opposite side, the ventricle starts dilating. So basically, there is an extra component inside the brain expanding in this semi-rigid box. So what is supposed to happen? The substance that is inside this is going to get compressed and the perfusion in the brain is going to get affected. Severity was tabulated by the GCS to mild, moderate, and severe head injury, and giving rise to different recovery rates and disability rates. So any patient that comes to us, now this patient's relations came the following day, and they want to know whether this patient is going to die. So we need to know some numbers, and our number is if the patient comes with severe head injury where the GCS is less than 8, there is 30% die. Those are world numbers. So otherwise you can't have better numbers than that. So those are world numbers. 1/3 would die. What happens to the other 2/3? So they ask whether this boy can ever go to work. So the answer to that is 2/3 of that 2/3, that is about 60%, would have some kind of neurological deficit after 6 months. So that is the kind of damage a patient with severe traumatic brain injury would have. So let us see what's the working diagnosis. This patient has severe traumatic brain injury with no significant other injuries with partial fluid resuscitation. So that is the state we are in now. And because this is trauma, it's multiple trauma, because no head injury will occur by itself except bullfight, bull going in for bullfighting. Head injury will never occur just by itself, other than someone comes and hits with a barge pole. So there will be suspected cervical spine injury, chest injury. So we consider it as polytrauma, and all the polytrauma patients are treated according to an ATLS protocol. We all say as soon as damage occurs at the time of impact, this is an acceleration, deceleration kind of injury. The head goes and bangs on this lorry at extremely high velocity, and there is damage. And what happens at the primary damage cannot be revoked. That is the said story behind traumatic brain injury. Primary damage is irrevocable, and what we are supposed to do is to prevent secondary brain damage. So let us see what primary brain damage is. So there are, as soon as you hit your head, there are diffuse axonal injury, as well as the microscopic blood vessels that leads to the brain which supplies it gets ruptured. And there is a series of neuro-metabolic events taking place and neurotransmitters being released. Because of blood being liberated, there is large amount of catecholamines released into the brain tissue. There is catecholamines means there will be vasoconstriction causing ischemia. The neurotransmitters that are released are glutamate and aspartate, and activation of NMDA receptors. So what happens initially, because of this impact, these neurotransmitters are released and activation of NMDA receptors occur, and the cerebral vasculature becomes constricted, reducing blood flow. Ultimately, the cell wall starts dying. Why does the cell wall die? Because there is no energy. Why isn't there energy? Because the sodium potassium pump doesn't now work. And because of that, fluid starts moving into the cell and produces cellular edema and causes cell death. And in this process, calcium starts moving into the cell and potassium starts moving into the cell. By doing that, the cell becomes swollen and cell dies. So this is what primary injury is, and that is why we say we can't do anything about primary injury unless we prevent it. Any methods of preventing primary injury? Anything that you know of? In this particular event, road traffic accidents are the biggest killers in this country. Almost 7 patients die per day, even more than COVID today. And at least 7, every third hour person dies. So you can just imagine how many people, if 7 die, how many people would be in intensive care units per day. So that is the degree of damage. So how are I going to minimize primary damage? The best method is to prevent it. How do you prevent it? And in this boy's case, you need to wear a helmet. You need to wear a helmet. And by using helmets, you could reduce traumatic brain damage by 50%. And wearing seat belts, you can reduce it by 30%. So you can actually minimize hospital admissions if you actually wear a seat belt. And you see parents, doctors taking their children in the front seat without a seat belt. So pretty sad. Everyone has to wear a seat belt, even if you're seated at the back. So what is the rational approach? The rational approach here is the primary damage is actually causing the cells to die. How does the cell die? Because the cell wall gets less energy. When the cell wall gets less energy, that becomes permeable and calcium and so potassium starts going in, and this becomes big. At the same time, aspartate and glutamate is released, and there is cerebral vasoconstriction. So what we are targeting in this rational approach is improve the cerebral energy in the brain. How are you going to improve cerebral energy? You need to have a substrate glucose, you must have oxygen, and you must have something to bring it up into the brain. So glucose and oxygen is brought to the brain by something called the cerebral perfusion pressure. So cerebral perfusion pressure is going to bring it up, and glucose will be broken down by oxygen and thereby producing energy. Because this was multiple trauma and going by the ATLS protocol, ABC always comes before ICP. So airway, breathing, circulation needs to be sorted out. It's like in the Montessori, like Sama, Mama, Ava, these ABCs taught to us every day. So whether it should be ABC or CAB is not a controversy, but depending on the original ABG, we will decide whether to resuscitate cardiovascularly first and ARV and breathing second. Dimanta, any changes in the arterial blood gas that we will decide to do CAB? Anyone? Because we are going to do arterial blood gas on admission of this patient. So would we concentrate on circulation rather than airway if the blood gas is bad? So what numbers are we going to think of? So we are looking at a base deficit of 6, we are looking at a lactate of 4, and we are looking at a shock index of 0.7. So those are the 3 numbers. If those numbers are actually on, we need to be more concentrated on C rather than A. So anyway, ABC comes before ICP because you need perfusion before breaking this down. So secondary brain injury. So let's get to our main area. How are we going to maintain cerebral perfusion pressure? First, the evidence came by Rosner and Lund. These are the 2 people who are doing studies on cerebral perfusion pressure and ICP. Ideally, various people gave various numbers of bringing the CPP to 70 because to perfuse this brain. Currently, the number lies at about 60. So even if the mean arterial pressure we keep at 90, with the ICP of 30, you will get a CPP of 60. So that is why most of the time we ask for a map of 90, because assuming the ICP in a dilated, pupil dilated patient with increased ICP would be 30, and the CPP we will get at least a number of 60, which could perfuse the brain. What happens in traumatic brain injury? As soon as you go and hit the head, because of primary injury and trauma, the intrinsic capability of any organ to maintain blood flow, which is known as autoregulation, there is failure. Can you see the autoregulation curve? Everyone who knows what autoregulation will appreciate this graph where there's a plateau over a large mean arterial pressure, the blood flow is constant. But as soon as there is damage, the autoregulation curve gets disturbed. And ultimately, if there is no autoregulation, it's a straight line, and this straight line depicts that the flow is dependent on blood pressure. So if the blood pressure is too high, there'll be more cerebral blood flow. If it is too little, there won't be any blood flow to the brain. So this is an important factor in traumatic brain injury. Map. So these are the current guidelines. The systolic blood pressure between 50 to 70 years should be kept more than 100, and over 110 in elderly people and 14 to 49. Higher mortality has been noticed in patients whose blood pressure is less than 90. So any patient who's coming with traumatic brain injury, we will see that the blood pressure is pushed to systolic 90 at least before we go in for surgery. So how do we push this up? We push this up by giving fluids, and if fluids are unable to reach your systolic of 110, we will be starting inotropes. Then comes ICP. What is the intracranial pressure? Described mainly by Monro and Keley long years ago. He described that this was a semi-rigid box with 4 components. Let us break down. Some describe it as 3. I have broken it down to 4. Brain water, CSF, and blood are the 4 components. Brain matter and brain water, the whole thing constitutes of about 70%, out of which brain water is 60%. Then blood means not the hematoma, it is the volume taken by the veins and the arteries. Volume taken by the veins and the arteries. And these the volume taken by CSF. These 15%, this is 15%, and these two come to 70%, out of which matter is 10 and the other one is 60. So we can figure out if this is almost 60%. If you get rid of the water, there can be a marked reduction in the ICP. So there are 4 components in this semi-rigid box, and this is known as the compliance curve of the brain, and this comes at all exams of any postgrad. Intracranial volume on one side and intracranial pressure on the other. As the volume increases, like this EDH, as the volume increases inside the brain, initially what happens, the ICP does not go up. Why doesn't it go up? Because the brain is compensating. How does the brain compensate? By pushing the CSF into the spinal recesses and collapsing the veins, giving more room for the hematoma to expand without a pressure change. That is what happens at the beginning, and later the compensation is lost and the ICP starts going up. When the ICP starts going up, the CPP drops and the patient gets a lower GCS. So what are the situations where the ICP is high? So let us take the blood. The volume taken by the blood, I said, it is the vein and the artery that takes the volume. If the artery dilates inside, the component which took 15% will be more and the pressure would be more. And we know the secondary brain damage is due to these factors. Hypercapnia. Do we like patients with high carbon dioxide? No. Why? Because we know every time the CO2 goes up by 1 millimeter mercury, the cerebral blood flow increases by 4%. So that is the very reason we actually intubated these patients. Hypoxia is another killer. As soon as the oxygen tension starts falling, the blood vessels will vasodilate. And so if you look at hypotension is another. And if you look at most of the patients who come from the periphery from a local hospital, will have oxygen on board and will have an IV line running. So they also have figured out hypotension and hypoxia are the greatest killers, as well as hypercapnia. Then increasing the metabolism in the brain by fits or fever is another thing that vasodilates. Because if the patient is fitting or has fever, what will happen? The metabolism in the brain is high. So the need is high, the blood vessels will dilate. So these are all very significant reasons for secondary brain damage. So we need to stop hypercapnia, we need to stop hypoxia, we need to reduce fits, so give anticonvulsants, treat the fever, paracetamol on board, and see that hypotension or hypertension doesn't occur and patient does not vasodilate. How do you reduce venous swelling or venous blood vessels, the veins to get this? We have seen most of the patients with head injury, we will be keeping a head up tilt. Why are we keeping a head up tilt? But we want all the veins to collapse for blood to drain down into the heart. So jugular venous obstruction is reduced and high airway pressure. That is why when we are ventilating these patients, we don't ventilate with high PEEP or high tidal volume. And when you're using a cervical collar, you need to see that you use an appropriate size cervical collar, and otherwise the jugulars are getting compressed and cerebral venous congestion. The other reason for CSF hydrocephalus is a high ICP. Another cause is causing hydrocephalus because of CSF blockade. When brain water increases, there is cerebral edema. And if the brain matter increases, like in bleeding, again, ICP can go up. So these are the common reasons why ICP goes up. So let us move forward to figure out why in the current times we try to ventilate patients with traumatic head injury. Because there is definite advantage of having a definitive airway protection. Because as soon as we intubate, we protect the airway, and therefore we inhibit the risk of pulmonary aspiration. At the same time, by intubating and ventilating, we can achieve our goals of carbon dioxide and oxygen. So the Brain Trauma Foundation have given us guidelines how much of carbon dioxide you need to leave it at. So we are supposed to leave it at between 35 and 40, lower limit of normal, and oxygen between 10 to 13 kilopascals, which is about 80 to 100 millimeters mercury. So this is a graph from the level you're a medical student until you become finish your postgraduate exams. You need this graph. What happens here is when the oxygen level, this is the blood flow, and when the oxygen level reduces, tension reduces, there is cerebral blood flow increases. And when the carbon dioxide increases, the cerebral blood flow increases. So ICP goes up in both situations when there is hypoxia, that is here, and hypercarbia, that is here. So what we want to maintain is this situation here, which is about 50 ml per 100 grams per minute. So these are the targets given by the Trauma Foundation: PO2 of 8 to 10 and saturation of 90 to 95. So we don't need to go to 100. These numbers are quite adequate in patients like this. So what else can we do as in the rational approach in reducing traumatic brain injury? We need to reduce the cerebral metabolism. If you reduce the metabolism inside the brain, what happens? The blood flow to the brain will reduce and the ICP will reduce. So therefore, we need to give anticonvulsants. But the current thinking is that phenytoin, that is phenytoin or thiopentone or whatever CMRO reducing drugs, will reduce the incidence of traumatic seizures, post-traumatic seizures in the first 7 days. Is not recommended. Phenytoin is recommended to decrease the incidence of early post-traumatic, but not late. So in general, using anticonvulsants is not applicable according to evidence, but we do continue using it because we don't want patients to get fits, because these are class 3 evidence basically using anticonvulsants. But barbiturate administration, we use thiopentone infusions. Most of us in ICUs use thiopentone infusions, which is a short-acting barbiturate until a level where burst is suppressed, and that is reserved for patients with refractory ICP who does not respond to medical and surgical treatment. So what have we done to reduce the metabolism in the brain up to now? We have given anticonvulsants, we have prevented fever, and we have prevented fits and induced a barbiturated coma. Something that has been there in the past is, can we cool our brain? can we cool our brain and improve the brain function? Again, what happens is we are trying to reduce the cerebral metabolism. The thinking is it is not useful. It is useful only for patients with traumatic brain injury who have had a cardiac arrest and being treated after following a cardiac arrest. And the temperature that we are talking about is 37 to 35. That is moderate hypothermia. And why we are not going in for very low levels? We know that severe hypothermia can have coagulation problems, immunosuppression, cardiac arrhythmias. And because of these things, hypothermia is not encouraged except in patients who have had a cardiac arrest. So this is then comes to how do we get rid of the brain water, which is a very, very important fact because brain consists of 60% of water. And should we give mannitol to our patients with traumatic brain injury? Answer is yes, and the answer is no. Because mannitol is, these are again a class 2 evidence. Mannitol, the biggest problem it had was when a blood-brain barrier is broken, this mannitol can move into the area of damaged part and draw water into the damaged part and cause intracranial hypertension. But we do use it because our options are limited. So the dose is 0.25 to 1 gram. So if you use 1 gram, the method that it produces is these a highly osmotically active substance with an osmolality of about 1200. When it goes into the brain, it drags water from the brain tissue. That is what it does. It's avoided in renal failure. But what it does is it increases the serum osmolality in the brain. If you give 0.8, it goes up to about 310. Will drag a little bit. But if you give 1.2 grams per kilogram, it will go up to about 340, which will give a greater drag and reduce the cerebral edema. So this is the way mannitol works, and it's a class 2 evidence. Class 2 evidence, 2A evidence. That is to say, it is not standard practice, but it is used as a unit policy. So nowadays, we moved to 3% normal saline from mannitol. Any reason? In theory, it is said that immunomodulatory effects, it maintains the blood-brain integrity and restores the blood-brain barrier. So the neuronal membrane potential is preserved, and this is something new to us because we were all talking about the bad disadvantages of mannitol, and then comes this 3% normal saline. In children, it has a great advantage because the fluid balance is very much easier. Fluid balance is very much easier because you don't get such a diuresis like in mannitol, and these immunomodulatory effects and the restoration of the blood-brain barrier is a great advantage. So our aim is to get a target of 145 to 155 serum sodium, increasing the serum osmolality and drawing water as much as possible. These are all still the recommendation does not say that one is superior to the other. Another method, if you go back to the 4 that we are talking about, and taking the CSF out also has an advantage, reducing the volume inside and reducing pressure. So using an EVD, external ventricular drain, reduces the ICP. That is also used by us, and especially in repeated CTs if there is hydrocephalus. This is again something that we use quite often today when the patient's GCS does not improve. If you can see this CT, why we did this was because there is intracranial hypertension or ICP has gone up and brain is coning. When coning is noticed, the surgeons, the first thing they do is to open the brain, giving room for the brain to move this way rather than going down. So this is known as a decompressive craniectomy. decompressive craniectomy, and the dura is open and the brain comes out that way without pressing down. It's favorable. Numbers have actually improved, but there is a massive disadvantage. What is the disadvantage? If the GCS was 13, 12, 13, it will improve to 14, 15, and patient becomes better. But if you do this to every patient whose GCS is 5, 6, you will keep vegetative patients of GCS 10 in the ward in large numbers. So this is a great drawback in this decompressive craniectomy, and you don't want the neuro wards to be filled with patients who are vegetative either. Should steroids be used? Steroids, no. The crash trial actually designed has given us great evidence, class 1 evidence basically, saying that steroid should not ever be used in traumatic brain injury, and it has increased the mortality. And why it was used, they thought that free radical scavenging properties and altered the restoration of the altered permeability, all those things are untrue in relation to ultimate mortality, and they have stopped using steroids in head injury. And infection as a prophylaxis, yes, definitely we have to have the patients on antibiotics because they are on invasive monitoring, mechanical ventilation, and patients requiring ICP monitoring. And these, the infection rate is extremely high, and they have to have prophylactic antibiotics on board. Early tracheostomy is advocated, and we use percutaneous tracheostomies today, and that has reduced the period of mechanical ventilation in ICUs. But the nosocomial infection is reduced by tracheostomy. That is a myth. It does not reduce the nosocomial infection, or VAP does not reduce by having tracheostomies, but definitely the time period mechanical ventilation is reduced. The EVDs, we can use antibiotic impregnated catheters, and even CVP lines, there are antibiotic impregnated catheters, mainly vancomycin and rifampicin are the substances that they dip it in, and that has great advantage in reducing infection. DVT prophylaxis, should we treat them with enoxaparin? Head injury patients, yes, low molecular weight heparin or low dose heparin can be used and should be used with support of mechanical prophylaxis. Reason, when should you start? Should you start on the first day, on the third day? The recommendation is start from the third day if there's no expansion of your hemorrhage. And we, in our ICUs, we use pneumatic calf compressors, which is of sequential type, as well as on the third day, if there is no contraindication, we start enoxaparin. Glucose control should be tight, should not be, initially it was tight, but we have relaxed it to 110 to 180 because hypoglycemia was a killer when tight control was practiced. Tranexamic acid, wonder drug in the last decade, initially started to be used after a study that was done in Iraq during the Iraq War. They started giving tranexamic acid in head injury patients, and definitely it's a class 1 evidence today in traumatic brain injury. What do you think the future of this traumatic brain injury would be? Are there any novel therapies? Now, going back to our primary injury, what would be the novel therapy? You go back and see, we said in primary injury, neurotransmitters are released. What are they? Aspartate, glutamate, NMDA, antagonist. So if you give something to antagonize them, can you minimize primary trauma? So that is one. Any other thing that we can do? They have actually even tried other methods. So let us see as we go. Neuro-repair strategies, the brain has now got injured, and neuro restoration happens immediately. That is neurogenesis, gliogenesis. So they are trying to produce glial cells, neurons, blood vessels as soon as, and sprouting axons as soon as injury takes place. So these growth factors will stimulate as soon as any damage takes place. But in traumatic brain injury, this restoration does not take place. That is why these patients, the penumbra dies. So what do? Can we give a cocktail of drugs which will regenerate the neurons? Yes. So they have actually tried mesenchymal cell infiltration, which is stem cell infiltration. Stem cell infiltration actually started with spinal cord injury, with Christopher Reeves. You all must be knowing Christopher Reeves, a famous name. The Spider-Man, when he got injured and he was paralyzed. Superman. What happened to him? He spent all his money on spinal cord research. And today that has led us to mesenchymal stromal cell infiltration in brain injury to prevent primary damage. And what we try to do here is trying to get pluripotent cells from the umbilical cord, amniotic fluids, and the bone marrow, and to make it differentiate into neuronal cell and glial cells. So this is happening based on clinical practice and safety. They have started using this in animal models, and I think they are quite successful with it. And the other one we spoke about is excitatory neurotransmitter. Taxoprodiol is the drug of choice, NMDA receptor antagonist. Ketamine was once thought, but these are specific to the receptor. So that is why these have advantage over ketamine. And this has been tried to minimize primary injury. So the third method is they have tried sex hormones. Sex hormones are your estrogens and progesterones to reduce anti-inflammation and improve antioxidant properties. But those studies, the phase 2 of the rescue trial and the protect 3 trials, all have failed. So sex hormones are no more useful. Metabolic therapy, the way forward here is to use, other than glucose, some other substrate. And the substrate that we try to use here is ketone bodies or lactate. When the demand of glucose increases, we can give something like lactate to produce energy. So hypertonic solutions containing lactate have been used, and that is also a novel therapy. I won't go into neuromonitoring because we have actually run out of time. And these are the few things that I actually wanted to tell you. These intracranial pressure monitoring, which is used now, we use it, we put a catheter into the brain, and we get a waveform. And this is the waveform in increased ICP. There's P1, P2, P3. The P2 goes up when the compliance is low. And it's 60,000 a catheter. But because of the use of decompressive craniotomy, the use of this has come down. And the use of ICP monitoring is also a phase level 2 evidence. So, and advanced monitoring using tissue oxygenation in the brain also is a way forward. You can actually grow up to the damaged part of the brain and get the oxygen concentration. So these are the way forwards in traumatic brain injury. So basically, in a nutshell, what we have spoken in the last 45 minutes, we have spoken whether there was a rational approach in treating traumatic brain injury. There have been, in the past, have the numbers come down? Have we improved the mortality? If you look at what we have done 20 years ago and today, we are all intubating patients in the ICU. But if you look at the world figures, there is a 10 to 15% improvement in the management of these patients. Why have they improved? Why have they improved? Because from the time of impact to get to hospital, there is better ambulance services. They they are intubated early, and we go by evidence-based practices. We use Tranexamic acid, whether we should give mannitol in this patient, whether we should repeat the CT, keeping cerebral blood perfusion pressure and the mean arterial pressures at different points. So all these have been studied over the years, and I think those are the things that actually have improved the outcome of these patients. And we can rely on our physiology today. Now, everything I told you was based on physiology, and this has actually helped. And looking back, not looking forward, the future is hopeful, because with new restorative modalities coming in for the brain, more stem cell activity, stem cell studies coming out, there is a great advantage. So every patient who comes with head injury, remember, they are part of multiple trauma. They have to be treated as multiple trauma and adhere to the ATLS protocol. Thank you. And any questions? No questions, because I have done the same thing with the emergency medicine guys 2 weeks ago. So Arindi is going to ask a.
No, I'm not going to ask.
Anyone who wants to. Okay, as there are no questions, I hope you have understood the traumatic brain injury and management, and you all will not ask the nurse what IV fluid to use in the future. And the IV fluid to use in the ETU is normal saline or stereofunding, or it has touch of that. Madam, any questions? Right. Okay.
So, no questions from the audience. So thank you very much, sir, for class one lecture from class one concern from class one hospital. So yes, so I will. Yeah.
Yes, now bypassing us, and when they come here, when you send these patients back again, saying, "Oh, I see you," how frequently do you want us to call? Following day after,
How often do you all need to call us?
Yeah.
Please don't call us, call the neurosurgeon. The anaesthetist need not be called. If there are no ICU beds, that is the reason that we have sent the patient to you all. Is that right, Uday? Patients have been managed with novel therapies. Thank you.
So thank you very much, sir. So the class one lecture, but next week it's going to be challenges in managing safety. So we will use the class one from Professor Vasant to do the lecture. So anyway, I call upon Dr. Arvekola, sir. Yeah. Class one. Right, sir. Anything? Sir? Yes, sir.
Thank you very much for attending this lecture. And just a small announcement, because now we know that there is around the corner, and hope that we should be able to tackle and continue with that. But in the light of that, we have to unfortunately cancel the English preparations for having this Monday. But alternatively, we are trying to organize an online program to educate the families, children, etc., on the customs and the traditions of gaming, etc., only for a short while, about 1.5 hours on through Zoom. And if this is successful, soon we will send you